right. Hey everybody, Dr. Rafich here from Vet Triage. We are going through this October 2016 issue of JAVMA. We are at the ECG of the month. So we'll go through this interesting case. Bear with me. These are always the most difficult ones for me to explain on this channel because you have to look at ECG readings, which I don't have an easy way of showing you, nor would I even know how to point things out to you anyway. And so I'm just going to read it off, and hopefully it'll help some of you with some basic electrocardiogram readings. 13-year-old Dachshund presented with acute pulmonary edema. The dog had a dry cough for 2 weeks and a grade 5 out of 6 left apical systolic murmur. The femoral pulse quality was fair, and sometimes asynchronous beats were noted. The serum biochemical panel and complete blood count were normal. Echocardiography showed mild and moderate tricuspid and mitral valve insufficiencies, respectively, moderate left ventricular and atrial dilation, and systolic dysfunction. They started the dog on enalapril and furosemide and pimobendan. And this study comes out of Brazil, by the way, from a cardiology department. On the ECG here, they are saying that there's wide QRS complex tachycardia with a right bundle branch block pattern. The ventricular coupling interval was regular at 340 milliseconds, and that's in this figure here. And the QRS complex duration was 73 milliseconds. The inability to clearly identify P waves made differentiating between ventricular tachycardia and supraventricular tachycardia with ventricular conduction disturbance difficult. At this point, the three differentials were accelerated idioventricular rhythm, or ventricular tachycardia, or supraventricular tachycardia with wide QRS complexes. Then they had two other ECGs. I'll try to show them to you here. So there's the top one, and then this bottom one. We're going to go over those next. For the top one, they said, note that the predominant rhythm is ventricular and there is a captured beat. The captured beat has a normal QRX complex morphology. And then for the bottom ECG, notice there's a fast run of supraventricular tachycardia. The diagnosis of ventricular tachyarrhythmia was supported. They tried pharmacological cardioversion with lidocaine that failed to achieve conversion to sinus rhythm. An attempt to convert was then made with bolusing imidodronate hydrochloride. Then the dog went home with imidodronate or amiodarone. And discussion. Supraventricular tachyarrhythmias are most commonly confused with ventricular tachycardias when the QRX complex are wide. Wide QRS complex tachycardia of supraventricular origin may originate when there is marked left and right ventricular enlargement, pre-existing left or right bundle branch block, arterioventricular nodal conduction over an accessory pathway, or a functional left or right bundle branch block, meaning an aberrancy conduction. To date, no specific algorithm for differentiation of ventricular tachycardia from supraventricular tachycardia is available for use in the veterinary medicine. However, the morphology of the QRS complexes association of P waves with QRS complexes and the presence of fusion beats can be considered the most reliable distinguishing criteria. Ventricular arrhythmias are common in dogs with congestive heart failure attributed to dilated cardiomyopathy and chronic atrioventricular valve disease, myocardial hypertrophy and fibrosis, local and acute ischemia, electrolyte imbalance, especially with hypokalemia and hypomagnesemia, catecholamines, and myocardial stretch are considered underlying mechanisms for ventricular arrhythmias in dogs with heart failure. Accelerated idioventricular rhythm is an ectopic cardiac rhythm characterized by 3 or more consecutive ventricular complexes with a rate faster than the normal ventricular intrinsic escape rate at 30 to 40 beats per minute, but slower than the ventricular tachycardia rate. And accelerated idioventricular rhythm becomes evident when a focus that should normally be suppressed increases to a rate faster than that of the sinus node or the arterioventricular node. The underlying electrophysiological mechanism is associated with abnormalities of the ventricular myocardium, like high vagal tone and decreased sympathetic nervous system activity, and altered automatism of the Purkinje fibers. When the enhanced automaticity in the His Purkinje fibers or myocardium surpasses that of the sinus node, the accelerated idioventricular rhythm becomes the dominant rhythm. Sinus bradycardia may facilitate the appearance of this rhythm. Generally, it is an intermittent and transient rhythm, although it may persist for some days, which is well tolerated and rarely causes hemodynamic compromise or hypotension. Additionally, this rhythm does not require treatment. An exact determination of the upper cutoff heart rate limit that differentiates this rhythm from ventricular tachycardia is not provided in the veterinary medical literature. Some research has suggested a ventricular rate limit of over 180 beats per minute can be used to differentiate that rhythm from ventricular tachycardia. As a general rule, dogs with ventricular arrhythmia and a heart rate of over 160 beats per minute should be treated. Those with a heart rate less than 120 are not treated, and those with a heart rate in between are sometimes treated. However, accelerated idioventricular rhythm or ventricular tachycardia should not be diagnosed on the basis of heart rate alone. A ventricular arrhythmia is judged to be dangerous when it causes hemodynamic compromise like heart failure, hypotension, syncope, or weakness, and when it may degenerate into a more electrically unstable and fatal arrhythmia. Even so, heart rate is the most important determinant of hemodynamic compromise because it pertains to the arrhythmia itself. As a general guide, most dogs will have substantial hemodynamic compromise when the arrhythmia is sustained for a duration of over 30 seconds at a rate of over 250 beats per minute. Myocardial failure combined with a fast heart rate has an important role in the development of congestive heart failure. For this dog, acute conversion to sinus rhythm after the intravenous administration of a single dose of lidocaine and amiodarone was not achieved. This may be due to failure of the treatment, such as choice of dosage, or the administration method, like bolusing versus constant rate infusion. A gradual 25% increase in the lidocaine dose may have abolished the arrhythmia. Likewise, a constant rate infusion of amiodarone instead of an intravenous bolus may have achieved a better effect. And then this is showing here a normal sinus rhythm in this dog after the treatment. Yep, so that's it. That's that paper. Interesting one. A lot of it goes above my head, but hopefully help some of you folks who listen to this video. I'll see you again in the next one. Take care.